Intravenous fluid therapy is routinely treated as a generic mechanism for hydration. In reality, it is a precise pharmacological intervention designed to target specific physically separated compartments inside the body. To understand how fluids behave, we use the model of the milieu interior. The body is a rigidly partitioned hydraulic system governed by the 60-40-20 rule. Total body water makes up roughly 60% of a patient's overall body weight. 40% of that body weight is water locked completely inside the cell walls. This is the intracellular fluid, or ICF. The remaining 20% comprises the extracellular fluid, representing all the water situated outside of the cells. That 20% extracellular volume is further divided. 15% bathes the tissues as interstitial fluid, while the remaining 5% circulates as intravascular plasma. We can calculate this exact volume. For a 70-kilogram patient, 60% weight is 42 liters total water, 28 liters inside cells, 10.5 in the interstitium, and exactly 3.5 liters of circulating plasma. The chemical composition varies across these boundaries. Cells function as closed bags of potassium, sequestering it almost entirely in the intracellular fluid, while sodium and chloride dominate the extracellular spaces. When clinical fluid resuscitation fails to improve a patient's vitals, it is almost always because the practitioner infused volume into the system without calculating which specific compartment actually held the deficit. The mechanical boundary separating the intracellular and extracellular compartments is the cell membrane. It allows water to pass freely, but strictly limits the movement of most electrolytes. The barrier between the plasma and the interstitial space is the capillary membrane. It is permeable to both water and electrolytes, but physically blocks massive proteins like albumin. Because albumin is trapped inside the intravascular space, it generates continuous oncotic pressure. This inward osmotic pull is the primary force keeping fluid circulating in the vein from leaking into the surrounding tissue. Tissue edema, often called third spacing, is a mechanical failure of this barrier. Either the capillary wall becomes too permeable from inflammation, or a failing liver stops producing enough albumin to maintain that necessary oncotic pressure. Fluid movement between these tanks is dictated by tonicity, whether a solution is hypertonic, hypotonic, or isotonic compared to baseline plasma. Tonicity gradients create an osmotic pull. Water is physically forced to move across the membranes toward the higher concentration of solutes until equilibrium is reached across the entire system. The specific tonic nature of an intravenous fluid acts as its targeting mechanism. It predicts exactly how a full liter of fluid will safely distribute once it leaves the IV line. Isotonic crystalloids follow a rigid 3-to-1 distribution rule. For every liter infused directly into the vein, 75% rapidly leaks out into the interstitium. Only 25% remains in the plasma to expand intravascular volume. Ringer's lactate is formulated to closely mimic human plasma, making it the preferred resuscitation fluid for most surgical and trauma environments. It contains sodium lactate. As the liver metabolizes this lactate, it converts it into bicarbonate, providing a natural physiological buffer against acid-base disturbances. Because of this specific metabolic pathway, Ringer's lactate is strictly contraindicated in patients with severe liver failure. Without a functioning liver to process it, the lactate rapidly accumulates, worsening lactic acidosis. Normal saline, which is 0.9% sodium chloride, lacks any buffering capacity entirely. It contains a highly unphysiological concentration of chloride. Pumping large volumes of normal saline into a patient overloads the kidneys with chloride ions. This suppresses bicarbonate reabsorption and swings the blood pH straight into hyperchloremic metabolic acidosis. However, normal saline has highly specific use cases. It is the fluid of choice for patients presenting with hyperkalemia or those with traumatic brain injuries, where the slightly higher sodium concentration minimizes brain swelling. Ringer's lactate and normal saline behave differently on a cellular level. The choice relies entirely on the patient's existing metabolic state and organ status. Dextrose 5% in water, or D5W, operates as an intravenous delivery vehicle for free water. Once the body metabolizes the suspended glucose, pure, solute-free water is left behind. Unlike sodium-based crystalloids, free water does not respect extracellular boundaries. It diffuses perfectly across all three compartments, ultimately pushing volume deep into the intracellular space. Colloids, like albumin or hetastarch, serve a completely different mechanical purpose. They act entirely as plasma expanders. Because their structural molecules are too large to cross an intact capillary membrane, colloids remain strictly inside the intravascular space. They pull volume into the vein and hold it there without causing tissue edema. Blood products, such as packed red blood cells, fresh frozen plasma, and platelets, are utilized exclusively as targeted therapies to restore oxygen-carrying hemoglobin or precise clotting factor deficits. The tools of resuscitation range from diffuse volume expanders designed to reach every cell to heavy intravascular molecules built to hold pressure within the pipes. This table breaks down the parameters of hemorrhagic shock. In severe physiological states, specifically class glaze and class 4 hemorrhage, the patient has lost up to 40% of their total circulating blood volume. Restoring perfusion in this state requires immediate, massive volume replacement with crystalloids like Ringer's lactate, quickly followed by whole blood transfusions to keep the organs oxygenated. This page documents the calculations for burn injuries, which require a completely different mathematical approach. The primary tool is the Parkland formula: 4 milliliters multiplied by the percentage of total body surface area burned, multiplied by the patient's weight in kilograms. As illustrated in this diagram, clinicians map that surface area percentage using the Wallace rule of nines, systematically dividing the anatomical regions into 9% increments to gauge the exact scale of the damage. Severe burns trigger massive systemic inflammation and capillary leak syndrome. Because those physical capillary barriers are destroyed, colloids are strictly avoided in the first 24 hours. Administering them early causes massive proteins to leak into the tissues, permanently dragging water out of the veins and causing severe edema. In trauma bays and burn units, the physical speed of fluid administration must be calibrated exactly to the mathematical formula driving the therapy. Complex metabolic states require specific compartment targeting. In diabetic ketoacidosis, severe osmotic diuresis forces the patient to urinate away massive amounts of free water, demanding precise replacement of that deep intracellular deficit. Conversely, in patients with cerebral edema, administering hypertonic saline leverages extreme osmotic pull to physically drag excess water out of swollen brain cells and back into the vasculature. These fluid interventions are designed to counter the lethal progression of shock, whether the primary failure is distributive, obstructive, cardiogenic, or hypovolemic. This schematic details the integrated pathophysiology of shock. As systemic pressures drop, baroreceptors trigger intense sympathetic nerve activity, rapidly increasing heart rate and forcing peripheral vasoconstriction to maintain core organ perfusion. Using the comparison chart at the top of the page, clinicians compare these states physically. Hypovolemic and cardiogenic shock present with cold, clammy extremities due to intense vasoconstriction. Early distributive septic shock, however, forces the vessels to dilate, resulting in warm extremities and bounding pulses. Misidentifying the pathology turns the treatment into a poison. Ringer's lactate accelerates liver failure. Normal saline accelerates metabolic acidosis. Colloids administered early in burn patients guarantee intractable tissue swelling. Clinical fluid therapy is an engineering problem. Survival requires identifying the exact physiological compartment that is failing, selecting the proper pharmacological tool, and calculating the precise dose required to restore homeostasis.